considerations, so we don't want to stop here. We want to continue the program despite Ron's passing. So sustainability, I think we showed already with the 12 months with the results. We don't go to 2 years at this point. We do have a subgroup that I'm going to show on the next slide that may go a little bit beyond 12 months actually. What's important is this approach cost effective? There were editorials by some leaders in the hypertension world that thought this approach is probably too costly. Who's going to pay the pharmacist? Who's going to pay the barbers? Who's going to make sure that Barbershop's business isn't decreased because now they're spending time on measuring blood pressure and driving patrons away, which was not our experience at all. So these cost effectiveness calculations are in process as we speak. We work with UCSF, with Kristen Bivens-Domingo, and Columbia University to get these data published. So I don't have any data on this yet. And then implementation. Can we roll this program out in other cities, maybe even in LA further, but also in other cities? So we work with Vanderbilt in Nashville, Tennessee, got an additional grant to roll the same program out, exactly the same model, the same blood pressure monitors, the same medication protocol. Idea is training them down there to pretty much carry out the same study. This time it's not randomized anymore because we know that the treatment effect is real. This time we just want to show that it works in other parts of the United States. And then what would it take to scale this program nationally? So the pharmacist scope of practice has to be expanded. It's I think present in many states, but I think we have to work on getting this approved in other states nationwide. The adoption of hypertension treatment algorithms, and I'm not saying that our algorithm is the law. There's many other algorithms that we can come up with that may be more cost effective and equally effective. And then finally, adjustment of the model to increase pharmacist efficiency, and that's the point that I made before. So we also got a Medtronic grant, small grant that wants to show that we can achieve the same results with less pharmacist interaction, less in-person pharmacist interaction, and then after an initial roll-in period, do some telemonitoring, so video conference style interaction with the patrons, and blood pressure medication titration without the pharmacist having to drive to the barbershops, which would be saving a lot of cost, of course. And then acknowledgements, finally, of course, all the accolades belong to Ron Victor here. And unfortunately, Anthony Reed, he was a study doctor. He kind of shook hands with all the patrons that did not have a primary care physician, and he took over the role to be the prescriptive power and to prescribe medications for those patients. He unfortunately, over the course of the trial, also passed, which is very sad. And then finally, he is the funding sources that made all this happen. So I think that's the end. Yeah. Questions? I'll probably just sit down and we can talk as around the
Is there a question?
Yeah, please.
You're expanding to Nashville. Who are you using in Nashville?
Who are we using? Vanderbilt.
Vanderbilt?
Yeah.
Okay.
Yeah. And Aetna is involved with that too. So we got some seed money from Aetna as well because they wanted to specifically target, obviously, Aetna enrollees in that program because there is very large interest in outreach programs in there, in Aetna. So they're trying to get involved.
Nashville is the home of both Fisk University and Meharry Medical College, two historically black institutions.
The plan is actually, Meharry is involved. Medical students will probably replace Westat to do the initial screening and enrollment. So we'll use Meharry medical students to do that. We also have a person who's on faculty at Meharry. He has a dual appointment at both Meharry and Vanderbilt who's involved. He's going to actually assume the role of community physician champion. He's a cardiologist. So for all the participants who don't have a primary care provider, he will act as their primary care provider, sign the collaborative practice agreement to allow the pharmacist to prescribe for those patients. So.
Another question I have is, are you looking to expand to other areas in the country?
There's no set plans right now, but we are talking, we're actually having some local efforts to do this in LA in a more expanded forms with potentially other health systems. John Ebinger is working on that, and
Aetna, so CVS Aetna has some interest, so they're providing some financial support for Nashville. For them, these kind of see this as a test drive, but their ultimate goal is for us to help them roll it out in cities that have larger Aetna presence. So there's only like maybe 800 hypertensive black men in Nashville that are Aetna members. But in Jacksonville, Florida, in Philadelphia, in Brooklyn, they have a huge membership that this could have an impact on. So their goal is that they get to test drive it in Nashville and then hopefully have our assistance with rolling it out in these cities where they have larger presence.
Can I just, tailing on that, I just wanted to ask that if, to the extent this is a talk that you're giving other places, if you would highlight the role of these historically black I'm from Tennessee, I care a lot about these historically black institutions in it, both so they get credit and so that it adds credence to what you're doing, because I think that's, those are actually important parts of the infrastructure, and it's important that we always recognize what these partners are contributing. Thank you.
I think Dr. Osterweil had a question.
Yeah, very nice presentation, thank you.
thank you.
I wonder, have you calculated the PMPM cost for that? Because the patient per month cost for that intervention?
That's all underway now. That's all underway. So it's probably not cheap, but I'm guessing that it will be cost effective because the intervention effect is so great, and the potential reduction of MI, heart failure in these high-risk patients is just incredible. So it will be cost effective, I'm almost certain, but it also will not be a negligible cost.
The reason I raise that, because the new trend in the country pushed by CMS is to pay attention to social determinants of health. And if we poo-poo the issue of cost because it's very effective versus keep it simple, from our previous speaker, then we'll miss the point. So I encourage you to look at the lowest common denominator that gets you to the target and go from there, as opposed to go with fancy drugs, which just will support who, but not will support the masses.
It's a good point. It's a
So
good point.
Dr. Scott Flynn?
He was still talking.
No. I mean, the question probably in my mind should be, shouldn't we use the best drugs? I mean, should we promote the best drugs or the cheapest drugs? Should we promote?
The best drugs that do the job.
In
Evidence.
fairness, all of the
That do the
drugs we
job.
used in this trial were very cheap. So
Yeah.
we had a segment of the population that didn't have insurance, and we had partnered with a small community pharmacy who gave us all of these drugs for $4 to $10 a month. So, I mean, for some people, that's not a negligible cost, but the most expensive would be $10 for a 30-day supply. Everything else was $4. Amlodipines, pennies, irbesartan, even pennies. So most of them were cheap. We didn't always use telmisartan. Only if someone had insurance, it would be fine.
I think indapamide was even cheaper than clothalidone.
Yes, much cheaper.
So,
Yeah.
yeah.
Are your the study in Nashville, is that only in that patient study?
No.
Okay, so it's all covered.
Yeah.
So
We're going to try to
It's
get
a
as
small
many.
population, it's for a much wider population than just the.
Yeah, we'll still do the screening of all the people who come through those barbershops, but we're trying to enrich the cohort with Aetna members.
Question about your adverse effects, you said you only had 3 episodes of kidney disease?
It was all reversible. It was pretty much the thiazide type diuretic problem that you can have,
And you picked
increasing
that up
creatinine, you have to
Yeah.
dose reduce or
So that
stop the
implies that
medication.
for your protocol, you're doing blood work after the institute treatment?
With that
Yeah,
handheld
with
device.
the
we can
finger
do
stick.
it.
For the ISAT or whatever
Yeah,
it was?
yeah.
Okay. Yeah, because that certainly adds to your costs, because each one of those cartridges are like $40 or $50, so.
Absolutely,
Yeah.
yeah.
speaking of cost effectiveness, that's the second question of cost effectiveness. Yeah, looking for an ROI on that is, you know, even the CMS protocols are looking for how do you self-sustain or what's the ROI for these for CMS. So very important to nail that down. It sounds like your most expensive part, of course, was your pharmacist time. Is that right?
I don't think so.
Yeah, okay, so please help nail that down. And speaking from a health plan, we're always looking at that, trying to get cost effective. As you said, if you think it's gonna be obvious, it'll be cost effective, and I'm not so sure I would.
I
agree
think
with that.
preliminary looks from the folks that are doing the cost effectiveness analysis, they were very positive.
Right, because if you're looking at avoidance of.
If you look at qualities and, you know, the different cutoffs of 50,000, 75, whatever your cutoff may be, according to those metrics, it would probably be cost effective. But we'll see.
Yeah.
We'll probably have results May to June, they said we will have those results.
So we'd love to say that maybe a follow-up padding for that, because that
Yeah.
would be very important to see. Because usually those cost reductions are gonna come through reduced hospitalizations and or ER visits, which for hypertension control sometimes takes some time to prove out.
Exactly, yeah, yeah.
So we have Dr. Tracy Imlay that has a question when you're done. Scott, go ahead.
Thanks. Yeah, the last question was, for your scaling, you talked about your pharmacist had special training and all that, and I assume you have collaborative practice agreements that are formed by the PCPs. Was it difficult to get those PCPs to sign the CPAs, or?
I think I can talk to that, but I think it was not a problem at all.
Yeah, we never had any pushback from physicians unwilling to sign the collaborative practice agreements. So I think I had between 15 and 20 individual collaborative practice agreements with community physicians. Oftentimes they wanted to give me more patients than I was interested in giving. So yeah, no, we didn't have that. And California is a very progressive state for pharmacy practice, so we kind of expected that. It might not be the same in other states where they're not comfortable working with pharmacists as closely, but we didn't have that.
Yeah, in the old days in California, that was my turf, and you stay off of it,
Yeah,
right?
exactly.
And nowadays, folks are, there's plenty of hypertension on your own, that's
Yeah,
all.
enough to go around. Yeah, yeah, absolutely.
Thank you.
So this is just super great work and just awesome. So by the name Barbershop, were most of the people, members enrolled men
Yes,
in your trial?
all of them.
Is there a, I didn't want to assume, but I did some little. Is there any interest in your group in expanding to the other half of the population who would be women?
Sure, I mean, we focused on this because I think when Ron was designing this trial, black men had the worst outcomes. Now, new data shifts the groups a little bit, and black women aren't doing that great either. So I think it would be very wise to expand it. Barbershops wouldn't be the right venue probably, but there's been some studies in nail salons, hair salons, specifically for women. Churches, of course.
You had mentioned that you're sort of exploring, looking at different algorithms to go with. I'm just curious, as one potential candidate, would statins, as you know, introducing them for patients who are not just necessarily hypertension or have elevated hypertension, but have, you know, cardiovascular risk, do you think that would work in your model, and what would that take?
It would be such an easy further step just to prescribe a statin. And actually Ron, he was a purist, so he wanted to keep it clean, to actually look just at blood pressure reduction. We're not looking at mortality, so the benefit of the statins would be hard to prove within a year. And it may actually be detrimental for adherence if you just prescribe additional medications. So he wanted to focus purely on antihypertensive medications. But in a larger trial with cardiovascular outcomes, it would.
Unless you move it, the location to a restaurant.
I just want to say that in San Diego, quite a few years ago, we talked as a group, Dr. Dudl, Dr. Fremont, Dr. Flynn, many of the others, about doing collaborative practice orders across the community, across the whole community, to give pharmacists the power to manage both of those. And it would be really interesting to pursue it on a pilot basis here. LA is so big, but can we do it? Can I give the microphone to Steve Chen for a minute to get his answer to the ball rolling?
Why not? Well, before it comes, I did want to comment a little bit. We had a chance to meet, actually. I talked to Ron before he passed and about the next phase, which is sustainment. I was the same concern Joel expressed with the same ones we talked about. At the end of the day, it is, pharmacists are expensive, let's face it. What are ways that we can spread this work, sustain it, and with some minor adjustments? And you had a slide that some of those, things like telehealth, things like having technical folks be the hands and eyes and ears for the pharmacists. The original plan, we didn't talk about this before, but the original plan when Ron and I got together was that the patients we identified in the barbershops, that the care would take place in pharmacies. I don't know if you told me that.
Yeah.
And so my job was to secure pharmacies to be part of the project, and I failed miserably. I basically hit up every single chain pharmacy at the very top. We're talking about national, and we got denied by every single one. There was just no interest whatsoever. So I started to get independents engaged, and that just wasn't good enough for the project, right? That's why you guys in the barbershop do beautifully. So what we're doing now is we've launched a statewide collaborative that partners payers with pharmacies and trains them on the whole comprehensive medication management, but with an emphasis on things like this, what the barbershop approach to managing high blood pressure for patients. And we have, for example, Inland Empire Health Plan, we're working basically it's a value-based payment model that's shared risk that will fairly compensate pharmacists, not excessively at all, based on their ability to deliver the results. And I won't go into the details right now, because I think we're going to have some of those people come and speak to this group, maybe in the summer, late summer, I think.
You haven't gotten back to me the
Okay,
date,
I was waiting for you to tell me, but okay, I'm not going to give you a date. But we're taking that model, spreading it to other payers that are interested. So we're trying to find ways to sustain it at a reasonable cost to go through points. Is that what you're looking for, Hattie?
Well, that was a start, but let's hear from Janina Morris, and she had a question. I was really interested in collaborative orders, authorizing in a very large-scale sense in Los Angeles to manage blood pressure and lipids by protocols. Maybe a collaboration with the American College of Cardiology chapter Los Angeles, and maybe Florian, you could lead that.
Sure. We just can't do all from our report.
Comment really quickly, I'm sorry. So that's a great vision, Hattie. Let's bring it back to reality. And I'll be very transparent here. Basically, the SoCal chapter of ACC opposed the bill that was proposed, supported by Ron Victor, that would have made a lot of that happen. So we're in different places right now. We need some leadership discussions between the SoCal ACC and what we're talking about here, because there's some misunderstanding about what we're trying to do and how effective and safe it is versus what the cardiology community apparently believes.
Well, we have a wonderful liaison in the room with us here, who I think
Yeah,
can
I would
make a
love
big
that.
difference, because
To
really,
help.
how does this work happen? It's because individuals like Florian and Steve and Adair and Alan and Jim and Scott and Chloe and Keith and Janina and Tracy step up and put their arm around somebody who's a resistor and convince them, based on the facts and based on the life and death issue here, to change things. And if the specialists resist, maybe there's a workaround, because people are dying. We have some pretty loud and ugly numbers of deaths that are completely preventable. Disabilities, completely preventable. Why are we tolerating it? We can't be tolerating it based on a guild mentality.
Well, I think the good news is that most of hypertension is actually in the hands of primary care physicians and not of specialists. So I think from that angle, you can still get to a lot of the patients and make a big difference.
So how would you imagine a collaborative order in Los Angeles to expand the work of the barbershops? So we know that the pharmacists can make such a big difference, where they're working collaboratively with the smartest people to create the best cost benefits.
I mean, it could almost be a business model, I think. I mean, it could actually employ a lot of pharmacists that get paid and contracted by larger physician groups or insurance companies, and help control blood pressure.
I just wanted to clarify though that legally that can't happen. A CPA with pharmacists is with physicians and groups.
What legally can't happen?
You can't have a county-wide CPA for pharmacists to
Yeah,
potentially.
it's always between,
It
the
has to
physician
be-
group has to approach the
Correct.
pharmacist and
Exactly.
have an agreement.
Exactly.
But that
And what
can
law
happen.
is that we need to change?
Maybe a different conversation, Heidi, but yeah, well, there is a law that has to change, right?
Dr. Emmons, did you have a question?
Yeah, a question for Dr. Chen here. I don't have the mic, so I'll talk up. I'm wondering if we're going after the right population. We hear about Aetna, but there's a large percentage of the African American population that's relying on Medi-Cal in this state or Medicaid, Affordable Care Act, et cetera. So maybe we should look at, my question would be, maybe we should look for funding from the government sources that have to end up paying for the complications, of this larger population. Earlier, we heard about, go after the low-hanging fruit with the larger population. So what are the possibilities of that?
So that's exactly what, that's exactly what we had done with the bill. The bill was for Medi-Cal to pay for pharmacists to work with the Medi-Cal population. So since that hasn't worked out, there is a second attempt this year to pass that legislation. But I think more importantly, we've decided, let's go with where we know the money is, which is with the managed care plans that manage Medi-Cal. So we're going after the counties like IHP, like LA Care HealthNet, and proposing that we at least pilot or launch these programs. In the case of IHP, they're already sold. They're ready to launch this on a big scale. So I think that's what that's where we're putting most of our eggs right now in our efforts, is in the Medi-Cal population, to your point.
So my previous comment is now relevant, but, so then I'm curious, like, where is HealthNet and where is LA Care on this?
We had to convince them, first of all, that this would be a good idea, and most recently, word got back that they're ready to engage in the collaborative and launch some of these pilots that would involve pharmacies providing some of this care. HealthNet has a new medical director who we have to invite to these meetings, Dr. Alex Chen, used to be at Ultimed. He just took over, and luckily, we worked with him very extensively when he was at Ultimed. So we have a very good relationship. He brought in a new director of pharmacy that we're meeting on Monday. So very early with HealthNet, LA Care, moving along, IHP very far along.
So, we heard two amazing presentations here today, and the idea was that we would consider these two protocol-based approaches to reach more people. So I just would like to hear from anybody who has ideas of, how do we implement in LA? What are your ideas for implementation? And maybe let's hear from some of the people who haven't spoken yet. If you have ideas that you'd like to get on the table. Jeff Kites.
So, fair balance on the Novo Nordisk pharmaceutical company. Some of the research that we're doing, specifically around diabetes, is that there is some of the research that we're doing using consultants is identifying that California seems to be lagging behind in evidence-based follow through around guidelines. So for instance, in diabetes, for the first time, ACC has come out with diabetes recommendations. We have the new ACE, we have the new ADA. Very fascinating what we talked about with all and all that, but we really sort of missed the idea, the concept that, in diabetes, we're changing the game and elevating the role of specific GLPs who have done long-term studies to show a benefit above the standard of care that we've discussed all day long here, and that those, GLP-1s are not being utilized, and trending California is behind the rest of the nation in adoption of these, the guidelines are out there. So I guess some of the thoughts around that is, how do we educate physicians to prescribe towards the guidelines and then the evidence that is there, as opposed to, I recognize we want cheap medications, but $1 spent on medication without a value to it in outcomes is, to me, the most expensive medication that we have, that we utilize, even if it's generic and it's $4, and we're missing the boat on, MACE.
So we have a lot of hands up right now. Who wants to be the brave soul to take it? I mean, we have, okay, so Tracy, Imley, Kaiser, LA, and then we've got Dan Osterweil from Scan Health Plan.
So,
Jim Dudl.
I completely agree, in a perfect world, the medicine I want, right, is I want all and tall and everything, right? And I'd like it at a Ritz, when I get my medical care. I guess the struggle I have is there's a percentage of the population that gets that, really, and probably even at the Ritz, right? The percentage of the population that keeps me up at night isn't that population. The percentage of the population that keeps me up at night is this group of people that earns at poverty level or below poverty level, wants to have health care, can't get it for a number of reasons, but doesn't want to have a heart attack or stroke. And if they get a heart attack or stroke, it is the final straw in what is a house of cards for not only them, but their family, extended family. And I absolutely value new medicines that do amazing things, and I'm not saying that. But I think, what Dr. Dudl is saying, sorry,
Rader.
Dr. Weiler, and, sorry, we're gonna become friends later, and then I'm gonna know your name. Is, I feel like this talk is really about how do we reach that other percent? How do we get everyone on these really inexpensive medicines? It should be possible, and where I work, you look at, in most health organizations, right, we're doing 60 to 80%, we're doing a great job, everyone in this room is doing a great job, but none of us are reaching 100%. None of us are reaching 90%, right? That's, I think, and that's where my passion lies, is in that.
I think that was really needed here. And although I couldn't ask Dr. Dudl the question before, I'll ask you now. When you compare lipid treatment and glucose-reducing medications, and you look at the ROI, how many years you have to treat somebody to lower their hemoglobin A1C below 7 and get a cardiovascular benefit versus how many years you need to give them a statin and get cardiovascular benefit?
Yeah. The answer is really clear. You can't really just push on A1C because in the ACCORD study, when they did that, more people died of sudden death than they saved by dropping MIs. So the answer is a no thing. But there's two answers to this. Number one, I think the reason I gave grade so much time here was so you could use it. Now, if you took GLP-1s and put them in the grade formula, and if your outcome is population decreased heart attacks and strokes, and then you put in a rosuvastatin, and you look at what percentage are on rosuvastatin versus a lower potency, what percentage have a 70% versus an 80% adherence, and what would it cost for me to make that change, which will be near nothing. And then what is the cost per heart attack saved in the entire population of anything else you put in. You can do GLP-1, SGLT2, PCSK9, it doesn't really matter. put them in, and you'll see a population outcome. And that's what I think we in Kaiser want to do. We want to see the most good for the population. And then, of course, there are specific situations.